Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we'll be covering the highlights from the 2026 British Thoracic Oncology Group conference, where we're media partners with in Edinburgh. To begin, Robert Rintoul from the University of Cambridge provides a 2026 update on screening and testing from the UK Lung Cancer Coalition, a group that aims to improve care and services for patients with lung cancer through lobbying and collaboration with various organisations.
So the UK Lung Cancer Coalition is a group working with all the organisations in the UK interested in lung cancer, supporting them, and our work is really aimed towards improving care of patients with lung cancer, improving services. Our main focus is around lobbying and talking to politicians and NHS policymakers in order to affect these improvements. We work very collaboratively, as I say, with all the organisations in this space, such as BTOG and the Roy Castle Lung Cancer Foundation and others, and all the charities and so forth. We have a board of directors chaired by Dr. David Gilligan. We have a clinical advisory group, which I lead, made up from all the various groups within lung cancer, so chest physicians, radiologists, oncologists, clinical nurse specialists, surgeons, etc. And we also have a number of member groups, and these are generally the charities such as BTOG, EGFR, Positive, ALK Positive, Roy Castle, and so forth, who all input information to us as we synthesize this. And we work over the last 20 years or so, since UKLCC was set up by Professor Mick Peake in 2005, we have written a number of milestone reports. Our most recent one was around genomic testing, trying to improve and speed up genomic testing for patients, because we know it will affect around about 30,000 patients a year with lung cancer need genomic testing, and at the moment it's far too slow and too patchy across the UK. I've said UK a number of times because one important thing about the UKLCC is we are working across all 4 UK nations, and we're very keen to develop further work in Scotland, Wales and Northern Ireland. We've recently done a Scottish Matters pathway report, and also most recently a report working with groups in Northern Ireland, helping them develop and drive their pathways and improve services in Northern Ireland. Back in 2015, we set an ambition to try and improve lung cancer survival to 25% by 2025. Between the late 90s and about 2013, 2014, we'd driven it up from about 5% to about 16%. We set this ambition to try and get the whole community working towards 25 by 25, as we called it. The last hard data, the most recent hard data we have, we know 5-year survival is up to about 21%. But some recent modelling by Professor Neil Navani's group at UCL, whereby what they've done is they've looked at survival by stage, and we also now know the proportion of patients with lung cancer presenting at each stage, and that is obviously moving from stage 4 and stage 3 towards stage 2 and stage 1, particularly with lung cancer screening spreading across England more and more widely. And their modelling suggests that today the 5-year survival from lung cancer in England may be as high as 29%, which is really exciting news, and this really puts us on a par with many other countries across Europe and North America. Now, this is still model data, and it will be a number of years before we actually have confirmation of this, but particularly with the advent of lung cancer screening, I think it shows what can potentially be done. Over the last few years, our main focus has been supporting lung cancer screening. Particularly, we've now got NHS England, and the government in England have said they will roll this out across England to 100%. We're working with Scotland, Wales and Northern Ireland and their administrations to try and get lung cancer screening rolled out. Wales is starting in 2027, but we'd really like to see decisions made for implementation in Scotland and Northern Ireland as well. So CT screening for lung cancer is one of our work streams. We've also, as I mentioned, been doing a lot of work on genomic testing and lobbying to improve the speed at which genomic testing is undertaken, because this is going to really adversely affect patients unless we can speed things up. And we've also done a lot of work on health inequalities and published reports on that. Going forward now, our work plan for 2026 and 2027 is going to focus largely on around survivorship. So as more and more patients are receiving curative treatment for lung cancer, early stage lung cancer, particularly surgery and radical radiotherapy, we are seeing more and more long-term survivors. And also, we are seeing more and more longer-term survivors with novel targeted therapies, even advanced stage patients living for much, much longer than previously. And we're realizing that as we've in effect changed the natural history of lung cancer with this large, growing group of survivors, which is, really, really pleasing to see, it brings new problems. And what we're realizing is that more and more people are at risk of developing second primary lung cancers. In fact, it may be about as high as 1 in 8 of long-term survivors may be at risk of developing a second primary. So this year, next year, we're going to do this piece of work around survivorship. We're also working to support workforce discussions, because we're very conscious that there are shortages in certain areas of the workforce, particularly in radiology, pathology, genomics, clinical nurse specialists. And the third thing we want to do is take our work very much out into the regional areas and into Scotland, Wales, and Northern Ireland. We had a meeting with the Northern Ireland groups recently that Dr. Wendy Anderson organised. We had our 20th anniversary conference at the end of 2025 in London, but in the autumn of this year, we're planning a meeting in Scotland. So those are our main work streams, but our big announcement is back on the success of the 25 by 25. We're setting a new target. What we want to do now is we've set a new target of 35 by 35. We want to try and achieve 35% survival 5 years across all UK nations, not just England, which we've achieved with 25 by 25, but in Scotland, Northern Ireland and Wales as well. So 35 by 35 is our new ambition. If you'd like to know more about the UKLCC and the work we do, please go to our website at www.uklcc.org.uk.
Next up, Laura Dixon from the London School of Hygiene and Tropical Medicine in London discusses the recent State of the Nation report published by the National Lung Cancer Audit, highlighting encouraging progress in lung cancer care in England and Wales.
So the National Lung Cancer Audit has recently published our State of the Nation report, and it shows some really encouraging progress for lung cancer care in England and Wales. Firstly, we've seen an increase in the number of patients diagnosed with early stage disease, more than we've ever seen before. So it's about 40% of patients now being diagnosed with stage 1, 2 disease. This has resulted in an increase in the absolute number of patients who have undergone curative intent treatment options, such as surgery and radical radiotherapy. And we've also seen an increase in the proportion of patients having surgical resection for lung cancer. Promisingly, we're also seeing that survival is continuing to improve in lung cancer. However, there are some challenges that we're facing. So waiting times continue to be longer than the recommended pathway outlined by the National Optimal Lung Cancer Pathway, and we're seeing variation in access to treatments. And therefore, we face system-level challenges to try and increase capacity, not only for diagnoses, but also for curative intent treatment options. And that involves not just having more medical professionals who are able to provide those treatments, but also the allied healthcare professionals that also help to deliver that care. People such as lung cancer nurse specialists are really important for moving patients through the pathway effectively and efficiently. And they can also help to deliver equitable access to these treatments. One really important finding from the State of the Nation report this year and in previous years is that we're not having the proportion of patients with advanced stage non-small cell lung cancer and good performance status receiving SACT. And we're also seeing that the waiting times to receive SACT are too long. So there's definitely some work that needs to be done in this area to increase equitable access to SACT in advanced disease. One of the things that the audit is doing is looking at variation. So looking at So looking at access to that treatment rates in lots of different places to try to share best practice and also identify opportunities to improve rates of SACT in certain areas.
Following on, Mariana Brandao from the Jules Bordet Institute in Brussels discusses recent changes in ongoing trials within the EORTC lung cancer group, including Premier Lung, ICRIS Lung 01, and NEO-TIME.
So the EORTC lung cancer group is one of the biggest ones at the European Organization for the Research and Treatment of Cancer. And indeed, last year we had quite a changes. We changed the board. So now the chair is Jordi Raymond from France and the secretary is Liz Hendricks from the Netherlands. And I became the treasurer, the girl with the money. So we also have now, because we have a very active group with over 800 people and a third of them are young and early career investigators, which are a very dynamic force. We decided to create this young and early career investigator board of coordinators. So we also have people for the communication, education, and also translational research. So in terms of the ongoing trials that we have, so currently we have the Prima Lung trial, which is an academic trial looking at in patients with limited stage or extensive stage small cell lung cancer after induction treatment. If they don't have any brain mets and they are not progressing, they are randomized between prophylactic cranial irradiation versus brain MRI surveillance. And the objective here is to prove that brain MRI surveillance is non-inferior to PCI, and it's actually better in terms of quality of life and so on. The principal investigator of this trial is Corinne Feverfin from Manchester, and there are a lot of UK sites open. So it's a very important academic question that we have, and I hope that here in the UK people are motivated to include a lot of patients in this trial. Then we also have the ICARS trial, which is in a oligometastatic setting. Patients receive the chemoimmunotherapy and then they receive a local ablative treatment, either radiotherapy and or surgery to all visible lesions. And then they are randomized between semiplimab, so continuing immunotherapy, versus stop everything. And the objective here is to prove that continuing immunotherapy is better in terms of survival. So this trial is ongoing. Unfortunately, it's not open in the UK, but it's open in other European countries. And finally, we also have the BioRadon, which is an observational study in which we give radon detectors to patients in order to understand if this might be associated with occurrence of non-small cell lung cancer with specific mutations or gene fusions. And this is also ongoing. But we have a lot of other trials in development, so that I cannot, because they're still confidential, that are probably going to open up during 2026. So next year, I'm sure that we'll give more details. And then just to conclude, we also presented the data from the Nivo team trial last year at ASCO, which is done with ETOP. And we presented the data for the cohort 2 of patients with B thymoma and thymic carcinoma pretreated with platinum-based chemo, and they received nivolumab and ipilimumab. Unfortunately, it was a negative trial because the PFS at 6 months was around 20%, way below the 40% that we thought. But still, it's a very niche population we don't have many treatment options. So it was a very nice trial. And we have some patients, I have personally some patients that were controlled for a long, long time. So there might be a subset that might benefit from this immunotherapy. And lastly, we also published the different manuscripts of the stage 3 resectability consensus done by EORTC with a lot of other societies. So they have been published throughout 2025 in the Lung Cancer Journal. And the final consensus definition has just been accepted for publication in the Lancet Respiratory Medicine. So you'll probably have the final manuscript very soon.
Finally, Anna Bibby from the North Bristol NHS Trust describes the potential benefits and harms of incidental findings in lung cancer screening programs and the need to develop strategies for managing them.
The 3 key points that BTOG asked us to put into our talk, for me, the ones I stated were the incidental findings have the potential to cause harm in screening programs. But equally, on the flip side of that, some of them, it may be beneficial to report and there's potential benefit there. And the key really is knowing which is which and also what to do with them when we find them. And I think another key point that came through with some of the work I presented was about having integrated pathways downstream of what to do with those incidental findings and how we link up with primary care to make sure the findings are actioned and we're not just giving participants diagnoses and then not doing anything about them. So AI-based risk assessments are definitely the way forward, because at the moment, lung cancer screening involves a telephone triage, person to person, working through various questions. Now that can easily be done digitally or remotely, and there is an app in development to do that, which would, make life a lot easier for a lot of participants. It would remove some of the stigma around answering questions about your smoking history to a person in front of you who you might think might judge you. There is obviously issues with digital exclusion, and particularly with sort of older age groups who may not be as comfortable using apps or what have you. But yeah, that's certainly in development and nearly ready, I think, to be rolled out. In terms of biomarkers, so a risk assessment for discriminating, kind of indolent tumours versus aggressive ones, I don't think we have the kind of question or individual participant-based characteristics that will help differentiate that. So I don't think a risk score could do that. Biomarkers could, but again, we're not there yet, I don't think. So, biomarker development and testing is quite complex because there's an awful lot of places we can put them within lung cancer screening in terms of potential for diagnostics, potential for risk assessment, and even within risk assessment, are we identifying high risk people and bringing them into screening, or are we identifying low risk people and sort of pushing them out of screening to reduce the potential for harm in that group? So designing biomarker studies is incredibly complicated. Oh, and then equally, I guess the important bit is a biomarker at the point of having had a CT scan where you found something. Can a biomarker tell us, is this an important nodule? Is it likely to be cancer? If it's cancer, is it going to be an indolent one that we can watch for a while, or does it need, immediate intervention or investigation? So, and there's a lot of work going on out there around genomic markers, proteomic markers, epigenetic markers, but none of them are quite there yet. And there's a couple of big grants, I think, being worked up to look at those. So we need to do that first. It's the discovery translational science bit. And then we also need to think about how we implement that in clinical screening programs in terms of the resource, the time, the staffing and the personnel, and then also how we communicate that with participants, because risk is a really complicated thing to communicate. So yeah, there's a program of work to be done there.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.